Why do we do deep brain stimulation surgery or DBS therapy? How do we know, or how did we find out that this therapy is useful? It has a long history behind it. It was almost like an incidental finding that some patients who had bad tremors, either from Parkinson's or essential tremor, suddenly had their tremors disappear or cured after having a stroke. And when we looked at the brain on autopsy after those patients had passed away, we found stroke in those specific areas which we thought were causing these tremors. That gave an idea to the surgeon that the damage or lesion or stroke in the brain can cause cure of motor symptoms such as tremor. And many surgeons started exploring techniques to cause the damage or lesion in the brain to cure or fix those tremors. Initial techniques were much more crude or open surgery, so they will break open the skull or cut open the skull, and then with a knife they will go in and cut different areas of the brain to see if the tremors can improve. Eventually they found out that those certain deep areas of the brain, if we damage them or lesion them, that's when we actually see an improvement in the tremor or Parkinson's or similar symptoms. And that gave them an idea on which area to damage. And then it was followed by this invention of cautery or electrocautery, where a wire probe, when placed into the brain or and then turned on, can burn the brain. And actually it was first figured out how to burn a bleeding area, to burn that tissue and stop the bleeding in the skin. And then they thought they can use the same principle of burning the tissue in the brain to burn that very particular area without having to cut open the skull or cut into the brain to go into that area. So you can just make a small hole and push a wire into that exact spot and then burn it and cause the stroke, our cells, to fix the tremor. And it did work. And early on, in 1930s and 40s, they were able to create a frame, a metal frame to place on the brain so that we can guide the wire into the right spot, as it has to be in a very precise location. We now know that the precision of 1 millimeter is important to get the right results from some such surgeries. So in 50s, that became a common therapy option, to put a wire in using a frame guidance and then turning up the current and burning the tissue. There were some problems with burning the tissue. The damage was permanent, and if you didn't do it right, you can have good effects or bad effects forever or for a long time. And in 70s, they figured out that one way to know that the wire is in the right place is that if you start turning up the current slowly, then on a low amount of current, you can see the tremor disappear. But if you pull the wire out or if you turn it back off, then the tremor comes back. So they will turn up the current a little bit, they will see the tremor go away, and then they know they're in the right spot, and they will turn it up, yank it up to a high level so that they can burn the brain and cause that stroke, so that once they pull the wire back out, the tremors still don't come back. But someone had an idea that because they're having so many problems by burning the brain, why not come up with a system where the wire remains in the brain and that low amount of current can continuously be given to the brain so that the tremors don't ever come back. And that person was Dr. Benabid in France, and he reached out to Medtronic, the company that was making pacemaker in Minnesota in America, and requested a special designed or adapted pacemaker to do these kind of functions, and that's how the process started. And eventually, as we started doing it and we did research, we started getting better in where to place the wire in the brain, and how much current to give, what kind of currents to give, how to design the battery to be better, and so on and so forth.